All right, well, welcome back everyone from a really short break and hope you enjoyed the morning panel. Before we get started, I just wanted to also pay my respects and tribute to Jeff Miklos. I know that you heard from Mark earlier, but just wanted to say that he was a great friend and colleague to all of us, and we really are mourning his loss, and I think our movement will not be the same without him, but just wanted to say a few things before starting. To express that sadness. So welcome everyone to the LAN. We're excited for another great conversation this morning. We have a lot to be proud of the last 3.5 years as the LAN, and today is about celebrating some of those victories and then looking forward to what comes next. So when I came into my role 3.5 years ago and looked at the work of the LAN, one of the things that I thought was really important was to move away from the notion that the getting to APM adoption was the end game or the end result of what we were working for, and really think about healthcare transformation more broadly, that what we really want is a better healthcare system for patients, and we had set out a strategy, of course, to try to do that. The LAN has really stepped up, and I just wanted to recognize some of the changes and some of the progress that we've made over the last 3.5 years. We have adopted a new accountable care curve. We have set out a very clear definition of accountable care that has been widely pointed to, adopted, and used to define one measure of success. We've really thought about expanding our membership too, and the LAN's membership is not just bigger and more robust than it was, but we've added new voices to the mix, and I'm really proud about that. And as we're looking forward, we're really thinking about how we meet those accountable care goals, and so that's something that me and my colleagues have been focused on at CMS. And so today, again, we're going to talk about a little bit about some of our progress there and what comes next. So as you all know, we have set out that goal of 100% accountable care in traditional Medicare for all Medicare beneficiaries, and then also the vast majority of Medicaid beneficiaries. We're now at about 50% of Medicare beneficiaries in accountable care, and that's something that we've been celebrating. It's certainly an increase from 2021. And we've also really set out a path of trying to work together as colleagues across CMS and across the agency. Looking at the Innovation Center in particular, really pleased about the strategic direction that we've taken and the pathways that we've been building to try to get to accountable care through advanced primary care and our accountable care strategy, the work that we've been doing with both Dan and Mina to try to align what we're working on with CM and with CMCS, and trying to find a permanent pathway for all of our innovations over the long run. Some of that means looking for a way to incorporate our innovations into the shared savings program, and then looking for opportunities in the Medicaid program more broadly. But we know that there's still a number of providers who aren't in accountable care and aren't in value-based care, and we need to think about why that's the case and make sure that we are providing those opportunities for them. Part of it is we need to think about how to make moving into accountable care and value-based care more, I think, easier and less with less friction. I think we need to think about lowering the administrative burden, making the pathways more permanent. And again, that gets back to some of the work that we're doing together with the Center for Medicare. And so along those lines, in addition to celebrating what we've done here, I just wanted to give my colleagues, I'm happy to be here on the stage with my colleagues and friends from CMS, Dr. Mina Seshmani, who leads our Center for Medicare, Dan Tsai, who leads the Center for Medicaid and CHIP Services, and then Dr. Dora Hughes, who is our Chief Medical Officer and leads the Center for Clinical Standards and Quality. And so today we're going to talk a little bit about what we're most proud of that we've accomplished over the last 3.5 years. And then Dora, looking ahead, if you can talk a little bit about what your goals are and in your new role as you take this role on. So we've got a forward-looking response and then sort of a reflecting on accomplishments over the last 3.5 years. So I'll turn it over first to Mina.
Great. Well, it's wonderful to be here with all of you, and it has definitely been quite a journey over the past 3.5 years. And I think one of the things that I am most proud of is, Liz, what you were referring to, the collaboration that we have had across our centers. You know, coming in, I think Liz and I talked a lot about the pilot graveyard, where you do all of these tests of all these models, and then what? And I experienced that when I was, working at MedStar Health, leading care transformation, where, we participated in some of these models, and then you're like, and then what? And so we've really made a concerted effort over the past 3.5 years to take what has been shown to work in innovation center tests and scale them into the Medicare program. Liz has said it's like they're the ice cutter, and I don't know if that makes us a battleship or a oil tanker or what. But some examples of that, there was the ACO investment model, which in the Obama administration we had worked on to provide upfront funding to healthcare providers to become accountable care organizations. It was shown to be a very good investment, and it didn't go anywhere after that. So one of the first things we did was we scaled the ACO investment model into the Medicare Shared Savings Program through advanced investment payments to give prepaid shared savings to smaller providers. And in the first cohort, we got an additional 19 accountable care organizations. And particularly in rural and underserved areas, which we know has been an area that has been further behind in the transition to value-based care. And along those same lines, more recently, before even ACO REACH model has concluded, we have taken a lesson learned from ACO REACH and taken the health equity benchmark adjustment and brought that into the Medicare Shared Savings Program to, again, increase participation of safety net hospitals. And one more example I'll give is where we are bringing that concept of accountable care into the very chassis of the Medicare program, the physician fee schedule. Because I think we know that not every healthcare provider and beneficiary is going to be in an accountable care organization. How do you make sure that there are multiple avenues to get to the goal that we all want, that there is this holistic approach to care looking at quality and cost? So taking lessons learned from the primary care models of CMMI, where now Medicare for the first time is paying for community health services and care navigation for people with serious illness, and integrating behavioral health and primary care. So I think those are all examples of where the collaboration between the Innovation Center and Medicare has really enabled us to in a quicker pace, transform care for the 66 million people in the program.
And PC Flex as well.
And PC Flex as well. I was trying to not talk too long.
Well, and then also thinking about the RFI, or the request for information related to a global risk option opportunity. So I hope you'll see a pathway here. So a pathway for both the accountable care innovations as well as some of the primary care innovations. And we're going to also start testing our rapid cycle innovation program, where we hope to learn more about what works in care delivery, and maybe there's opportunities to scale those as well. Dan, what about you? Can you talk a little bit about what you're most proud of over the last 3.5 years?
Sure. Excuse me. I think Medicaid, anyone that's heard me talk, I talk about how much I love Medicaid, how much we love Medicaid. Medicaid really is not just a program on the side. It's
now larger than Medicare.
We'll fight around that.
Okay.
It's an incredibly important part and a bedrock of the entire healthcare delivery system, and we cover over half of kids. We cover over 1 in 5 people. We cover a lot of working individuals and families without Medicaid coverage, you're struggling to figure out how to make ends meet and putting food on the table, or healthcare coverage. Those are not things that you want people to be focused on, especially in the context of this forum, talking about health and outcomes. You can't even start to do that if you don't have coverage. And so I think first and foremost, the strides we've made across the country for coverage, I think I'm particularly proud of. And that has been true in a range of ways. Certainly, we've gone through on the Medicaid side, Medicaid unwinding, renewals, all that work that we partnered with the entire delivery system on over the past year and a half. We are at 80 million people covered still in Medicaid and the Children's Health Insurance Program. That's 10 million people above where we were pre-pandemic, and we're at historic highs for overall coverage rates, of which Medicaid has been a huge part of that, along with 4 states having expanded Medicaid. So we have about 23 million people now covered through Medicaid expansion. And so those pieces are really important. The other piece around the coverage element is reducing a lot of the friction and red tape that comes with Medicaid eligibility and renewals. And a lot of that, the whole Medicaid renewal process put a big spotlight on how cumbersome Medicaid, just the experience of going through that is for renewals. And we have doubled the rate of what we call ex parte auto renewals, which is people that are still eligible, state has access to data sources that say they're still eligible, being able to renew that person without a gap in coverage instead of having to chase that person with a letter that may or may not get to that person's where they're residing and so on. And so those are huge shifts because you can't even talk about healthcare or value-based care if people don't have health insurance coverage. And so that has been a really, really big focus that I think we are really proud of. And then beyond that, as we come to the delivery system components, I think we've put the program on a trajectory towards really focusing on what the availability and the network of providers, having that be much more equitable in Medicaid as to what the rest of us would be expecting for commercial and Medicare. And that's reflected in rates of reimbursement, trying to measure appointment wait times to provider directories, makes sense in charting that out. And in the context of this group especially, I think once you have those things in place, then you're able to really start to think about the value-based care piece and the population health approach. All of those are kind of really critical stepping stones, and there are quite a number of states who have, we've been really pleased to partner with alongside CMMI to try to push the needle and get more of that actual delivery of care off of a fee-for-service chassis, whether it be on the primary care side or with the HEAD model and things of that sort. So we've come a long way. There's a lot more to do. Coverage and access to providers is where we've put a huge piece of focus, and that really helps us set the system up for the longer-term population health elements.
And it's been obvious the ways that Mina and I have tried to work together because there's a natural connection in the fee-for-service program. I think we've been searching a little deeper to try to find those opportunities to promote accountable care and value-based care in Medicaid. Is there anything else you want to share about the progress towards the accountable care goals in Medicaid?
When I look at the numbers, I kind of like the fact that I can't remember all the numbers in my head right now. I think on some of the metrics, we are above commercial in terms of the adoption of APMs for Medicaid, and that's exciting, and there are a bunch of states that are really intrepid about that, same with a bunch of plans. We're not too far behind Medicare when I look at some of the numbers, and so that's really exciting and important to see when you think of the Medicaid program being as diffuse as it sometimes is, and it's been really exciting partnering with CMMI in a very different way, where with the intentionality of having innovation-centered models and the focus on delivery system reform, not just be about kind of the Medicare or the commercial book of business, but either Medicaid directly or a multi-payer state-level model with a huge anchor on what the state, including through the Medicaid program, is willing to do. That's exciting, and I think that's the direction we want to keep moving.
And Dora, you're new in this role, officially now the Chief Medical Officer at CMS and the new head of CCSQ, very officially, congratulations. And you've spent a lot of time thinking about measurement and quality measurement, and I know have worked across centers to think about measurement alignment, and we've made a lot of progress there. Can you talk a little bit, first, the role of CCSQ in the accountable care goals and your contribution to that, and then maybe just what you're looking forward to over the next couple of years in terms of the goals that you're setting as new in your role?
Sure, and I will say from the outset, I actually can't see the clock, and so you might have to cut me off because we have so much to talk about. But I would say, for those I haven't met, I did spend my first 2 years at the CMS Innovation Center. I've been acting at CCSQ for a year now in the permanent role. And so taking a step back, what really struck me about CCSQ are just the sheer scale and the scope of our responsibilities. We are responsible for the quality in nearly every facility in this nation. And that includes over 30,000 facilities that we are in every year. That includes 4,000 hospitals. That includes 14,000 nursing homes. That's 7,000 home health agencies. And an equal number, about 7,000 hospice facilities. And so it's a tremendous scale, and we are also responsible for 21 different provider types. And so for us, really, where the rubber hits the road when we're thinking about quality, it's the measures that we set, the standards we're promulgating, and really being boots on the ground, eyes on what's happening at the front lines. And so it's very exciting work, very meaningful work. And it's also why we're able to contribute to reaching the 100% or the vast majority of beneficiaries in accountable care relationships. Our focus, of course, is on the quality side of that equation. And about 2 years ago, in 2022, we put out the National Quality Strategy. You may be aware of that. And I do have to give a shout out. I see my colleague, Doug Jacobson, Dr. Michelle Schreiber may also be in the room, really helping to taking the lead on developing what in many ways was the North Star for us at CMS in terms of our focus on quality. We looked across 8 different goals, whether it's equity engagement, if it was outcomes, alignment, safety, resiliency, digital interoperability, digital transformation, scientific achievement. And that really then set the stage. So what do we do next? And in 2023, that's when CCSQ put forward the Universal Foundation of Measure Sets. Could we, across all of our programs, and Medicare, Medicaid, through the models, marketplace, what have you, agree, could we come to consensus over a small, I always want to say core set, but I know in Medicaid I can't say core set, a universal set of measures that we would all agree to use on the adult side, the pediatric side. And we also published that, and also encouraging our commercial payers the same. And so then, since 2023 and moving on to 2024, it's been for us really thinking about how else can we incorporate the universal measure set through our programs. As one example, we've been including these measures in the primary care MIPS value pathways, the MVPs measure sets, or also in the APP measure set. So we can certainly dive deeper into that, but that's really been exciting work. And I would also have to note, this year we will start launching the 13th scope of work for our quality improvement organizations. For those of you that are less familiar, CCSQ also houses the Quality Improvement Network QIOs, Quinn QIOs, and also the beneficiary family and family-centered care QIOs. And so for all of that then, that's really just an incredible set of achievements that are new on top of our current work. We still have to operate 21 different statutory quality payment, quality reporting programs. That's on top of developing, maintaining 500 measures. That's on top of really for us, CCSQ, operating the compare websites, the stars, the various designations, just a tremendous amount of work, but I really think is helping to move the needle in terms of getting, again, our goals and getting our beneficiaries in accountable care relationships.
And I've been on panels before with Mina, and she also brought that that passion for measurement simplification when she came as a practicing physician. I can't tell you how many times I've heard you tell the story of having a spreadsheet with 300 quality metrics and trying to figure out how to align to them. And so I feel like we've made a lot of good progress there. And Mina and Dory also both mentioned health equity, and Dan as well. I think that's another area where I feel like we've made really important progress as CMS over the last 3.5 years, and I'm really pleased that with all of the new thinking around health-related social needs and screening, looking for referrals and trying to address those needs, and building in the benchmark, as you mentioned, into the shared savings program. Is there anything else you wanted to share about some of the progress you've made on health equity just in the last 3.5 years? Because I think that's really been an area that I've been particularly pleased about, and I know you have also all been focused on.
Do you want me to start or someone else start first? You're the boss, you tell us.
Not really. Yeah, why don't you start, Mina?
I mean, I think for us in the Medicare program, the past 3.5 years, it really has been how do we make sure that we are serving everyone who relies on the program, knowing that when the healthcare system is not working, it's the people with complex medical and social conditions that fall through the cracks. So in the very foundations of the operating of the Medicare system, we have been working towards how do we make sure that it works for everyone. So it's things like we now require that Medicare Advantage plans, if they have more than 5% of their enrollees who speak a language, then they have to provide communication in that language, right? Again, just really thinking about how do you address barriers in the very operations of a program. With graduate medical education, thanks to congressional action, we have been rolling out 200 new GME slots a year over 5 years, and targeting those GME slots to rural and underserved areas so that people are trained and understand the needs of the communities that they're serving, and they're more likely to stay and practice there. So that way you're addressing workforce issues. And I think another area is behavioral health, where there has been tremendous disparities, lack of access to behavioral health providers. And again, thanks to congressional action, we have been able to open the doors for up to 400,000 licensed marriage and family therapists and licensed mental health counselors to be able to enroll and bill the Medicare program. And I think we all know that when you're looking at rural America, you're looking in inner city areas, they don't necessarily have psychiatrists who they can see. And so being able to expand access in that way in the very fundamentals of the program then starts to get to the disparities that have prevented people from being able to achieve their optimal health.
Dan?
The good thing is we have very similar themes, and I think across CMS we've been hitting on the same type of topics regardless of which center, which payer buck. Just taking through a few, from measurement, we put out rules that now for our Medicaid core set, we want to actually see reporting and measurement at the state level of disparities at a measure-specific level across a range of demographic and race ethnicity groups, and that helps baseline where we are. Then across coverage, I mean, so much of what I talked about earlier for making coverage easier to access and the friction that exists, we know from the data that people that are historically have had gaps in Medicaid coverage, not because they're not eligible, just because they're falling through the cracks and procedural reasons, those are disproportionately individuals of color. And so finding a way to have less friction so eligible people can stay enrolled without jumping through so many hoops is a really core part as well. And then when it comes to access, that focus on, is there a network of providers available, or is there workforce available? All those play in, and I think even on some of the Section 1115 demonstrations, we have worked through and are currently negotiating another one where we can support substantial investments upstream in behavioral health, primary care, other workforce, as long as they're then practicing in the safety net for a period of time, and that's really exciting for us as well.
And Dora, you get credit for drafting and really developing the the health equity strategy at the Innovation Center. But anything else you want to add in terms of what you've been, how you've been thinking about this issue?
Sure. With my CCSQ hat on, I would say that I mentioned that we operate 21 statutory quality reporting and payment programs. As of this year, we will have required screening across all of these reporting programs really understanding, again, that we need to think about the health of our beneficiaries more holistically. We need to think about their clinical needs as well as their social needs. And so it's one achievement. I would also note at CCSQ, we have several specific clinical initiatives that will have disproportionate benefit for underserved populations. One such area is our focus on maternal health. As all of you know, undoubtedly, women of color are 3 to 4 times more likely to have severe and negative complications during the peripartum or postpartum period. Very similarly, we also know that there's more that can and should be done, and so we've really focused on that and thinking about what are the measures, how can we incentivize participation in quality collaboratives, working with our colleagues in the CDC and HRSA. That's one example. A second would be our focus on organ transplantation. If you're a person of color, you're less likely to receive an organ transplantation and also have to wait longer. And so just this week, actually, we, working with our colleagues at HRSA, HHS, we now have a website that's focused on organ transplantation, OTAG, the Organ Transplantation Affinity Group. We also released a blog that's detailing some of our efforts. And so I do think it's really helpful at CCSQ, similar to my colleagues, that we're able to look across all of the work we do. How do we embed equity, but also able to do deep dives in certain clinical areas. And the final thing on the equity side, just as a final example, earlier this year we put out minimum staffing requirements for nursing homes. And I think just a similar theme, if you are lower income, if you're living in certain geographic areas, if you're a person of color, you're more likely to reside in a long-term care facility that has inadequate levels of staffing. And staffing is the key correlate to having providing quality care and long-term care facilities. And so that's a final area. And I do think at CCSQ, I know at some point we're going to talk about what are we going to do moving forward. It's really just trying to elevate our focus. It's not just healthcare, but it's also post-acute care. It's also long-term care, feeling very strongly that very much on the healthcare side, but we are we are our brother's keeper, if that's the right expression. And we need to be mindful of the continuity of care, the full continuum of care that our beneficiaries are receiving as patients as well as residents in our facilities.
And now, and you mentioned looking forward, so I know, and we're all now getting ready to enter a transition period. We're transitioning our roles, at least the 3 of us. I'm just wondering what advice you might give to your successors. This is for Dan and Mina. Thinking from the Innovation Center, I think one piece of advice that I would give is really thinking about how to listen to stakeholder voices and make sure you're reflecting stakeholder voices in the work that we do, and that includes patients. I think we want to make sure that we're hearing what people are telling us when things aren't working, when things are working well, what lessons can we take? And so I think that's one lesson that I would impart to my successor, is just to make sure that we're listening, doing a good job of listening. But Mina and Dan, any words of wisdom or parting advice that you might have for the future leader for CM and CMCS?
You want to go first?
Sure. I think the single biggest thing is treat the program the way you would want it if you, your kids, your family, your closest friends relied on the Medicaid and CHIP program. And that's probably true north, because there's a lot of, on all sides of any debate, there's interesting intellectual policy debate one can have, whether it's on value-based payment or the way to think about coverage or access or the right role between the federal government and states and what we're all trying to accomplish in Medicaid. Many of those dimensions have lots of puts and takes. Some, from my standpoint, are very clear. But I think the true north is run the program the way you would want it run for yourself if that's what you relied on. And so the amount of hoops and barriers and challenges and kids having to be uninsured for periods of time if a letter didn't get through in the mail for coverage, or accepting that folks in Medicaid should have access to a different network of providers, or have bigger hoops in place than the rest of the market, the rest of us, really flies in the face of that. So, but that, do to others what you would want done to yourself, I think that true north is the biggest piece I would strongly, strongly urge my successor to keep in mind.
Mina, how about you?
So I think, I mean, two of the things that I would have said are similar to, what each of you have said. First, really keeping the people that we're serving at the center of everything that we do. Ultimately, that is why we are in these jobs, so that we are able to provide what it is that people need from our programs. And that has helped, I know for the Medicare team, that has helped us tremendously when we have faced some pretty strong headwinds, right? I mean, we haven't talked about implementing the Inflation Reduction Act, right? Like biggest changes to the prescription drug program since 2003 in like 2 years flat. And that was really only possible because everybody was like, we're doing it for, the senior who told me about having like $17,000 of out-of-pocket prescription costs in a year, or the patient that I took care of who couldn't afford the antibiotic I wanted to prescribe for her. So we were trying to figure out, what to prescribe for her. The second is, along what you said, which is, really making sure that we are listening, we are engaging, and it's both to get ideas from all of you of where there are opportunities to improve the healthcare system. But then when we put out a policy in I think physician fee schedule was 3,000 pages this go around, in the Federal Register, that's not good enough. It's how does that policy change actually make its way to that person who is being cared for and the person who is caring for them. And that's also where the partnership needs to be, so that, that's why communities like this are so important, because you all are executing and making the change happen on the ground. And I think the third thing that I would say to whoever is taking my role is just what an incredible team of career civil servants that we have at CMS.
I think we would all agree on that one.
Yeah, it has been truly the honor of a lifetime. It has been the honor of a lifetime, I think, for all of us to work with mission-driven, incredibly smart, incredibly dedicated professionals who know more about our programs in their pinky nail than all of us put together.
That is so true.
And so really just everything that we have been talking about on this stage is because of the work that our teams do each and every day to not only make important changes to the programs, but just to keep them running, that day-to-day operations. And I think that's where, when you don't hear about something with operations, it's because everything is going well, right? And I think it's worth taking a minute to acknowledge how well our programs do run for, millions, 150 million plus people, so.
Great answers, and it has been a privilege. Dora, anything that resonates from you? And I know I was trying to wrap this up quickly because
we were running. I let Dan go first.
I know. We were running 10 minutes behind, and Dan has another meeting. On behalf of Medicaid beneficiaries around the country.
Thank you.
So Dora, anything that resonates in what they're saying, and any lessons that you take to heart as you take on this new role?
Yes, and I'm glad he had another meeting. I was like, is it something I said? But with all seriousness, I really certainly agree. Just the caliber and the commitment of the colleagues is just really unparalleled, and so I cannot emphasize that enough. I also, certainly for us, really focusing on the patient voice, the beneficiary voice, the resident voice, as well as the caregiver is extremely important. And I know I'm full of shout outs today, but I saw Purva Rawal in the audience, and even as we're wanting to make sure we're hearing directly from the individuals we serve, just being really clear in communicating what we are trying to do back. And I think when I first came on, I was talking to Perv, I was like, what is accountable care? How can we more clearly communicate that? And just really being very specific, being very direct, understanding how to translate more directly and easily to our providers as well as to the individuals you serve, I also think is very key. And the final area, just really focusing, for us here at CCSQ, where do we go forward? What is the vision? And thinking just with my quality hat on, for us, we have been quite focused on quality measurement, but we have been having internal cross-agency conversation about how do we get from quality measurement to quality improvement. There is a gap there. And what is it going to take for us to really move quality in ways that are tangible, measurable, very meaningful for the individuals we serving. And some of that is thinking about what are the quality measurement systems. We know that there have been public meetings talking about how do we layer quality, how do we layer in payment. That is one. I mentioned the QIO, that we will be having the big launch next year, but again, what is the technical assistance? What are the resources? What are the interventions that have to happen on the ground at the front line? Again, that would be meaningful. A third area is really thinking about the data. We've talked about digital transformation, and I know it's a whole nother conversation, but how can we, on both sides, how can we leverage the data that we have internally that can help to improve quality improvement? And just as examples, through our hospital quality reporting system, every year we get 25 million data submissions. If we think about our end-stage renal disease quality reporting program, in the last 12 months, we had 35 million data submissions. I could go on across our programs, but truly, how are we better able to leverage that data that we can look for patterns and trends and opportunities to, again, improve the quality that we're providing across the range of our facilities. And so that is certainly where we will be focusing on the quality side, not just at CCSQ, but working with Medicaid and Medicare and our colleagues in CMS Innovation Center, and where we very much would value partnership from all of you as we help, again, to think through how do we get to the quality improvement and then therefore to the outcomes that we expect.
Well, I think that brings us back to where we started, which is the role of the LAN in informing a lot of this work. And you talked about defining accountable care. What is accountable care? I think we've done a lot of really groundbreaking work in terms of defining, measuring, and actually making progress in moving in that direction. And just, this really is all about the patient. And I love how, Mina, you really framed it well, that this is on behalf of the patient. And instead of thinking about APMs as the goal in and of itself, it really is about providing that patient-centered care and transforming the health system into one that works better for patients. And thanks to all of you, I think we've made a lot of progress in that over the last 3.5 years. And just want to add to my colleagues that, serving in this role in the Innovation Center has been really the opportunity of a lifetime. And I've been really pleased to be able to serve in this role. It's been a real privilege, and also the chance to work with all of you and my colleagues on stage, and again, the excellent staff and team at the Innovation Center who just blow me away every time I get to meet with them and hear about what we're working on. So this is a little bit of a swan song for some of us, and also a sort of launching for Dora in her role as CCSQ director. So thanks to all of you. I think we'll wrap it up there and get on with the rest of the program, but thank you again. It's been an honor.